we've had for well over 10 years now. And we have had amazing speakers over the years. And once again, this year, we have an amazing speaker. So I'm very, very excited for today's Brandt Lecture in Women's Health. The Jacobs Institute has been around since 1990. It is the organization that puts out the peer-reviewed journal Women's Health Issues, publishing on a range of topics of exciting research relevant to women's health and women's health policy across the United States and North America. We also do a range of other projects, but the Brandt Lecture is one of our signature events. And again, this is a great time. I'm not going to spend much time now, but I want to pass this over to Dean Lynn Goldman. She is the Michael and Lori Milken Dean and Chair and Professor of Environmental and Occupational Health, and a leader in so many ways across public health. And she's going to give the formal welcome from the School of Public Health. Dean Goldman.
Thank you so much, Susan, for that introduction. And thanks to all of you who are in attendance at today's Brandt Lecture. It's my delight to welcome you to this 13th annual Edward N. Brandt Jr. Memorial Lecture in Women's Health. This event is indeed a highlight each year here at the school, convened by the Jacobs Institute of Women's Health. As many of you know, we normally hold this event in person, but we have moved it online this year because of COVID-19. Although I miss seeing the faces of our students, staff, faculty, friends, and community members in person, having the event online does make it easier for people to participate from other locations. Along those lines, I'd like to especially extend a warm welcome to members of Ed Brandt's longtime faculty home, the University of Oklahoma Health Sciences Center College of Public Health, and to Ed Brandt's family members who are joining us. I want to recognize and thank this event's co-sponsors, the Jacobs Institute of Women's Health, the Public Health Student Association, both here at the Milken Institute School of Public Health, but also at the Hudson College of Public Health at the University of Oklahoma Health Sciences Center. I'm thrilled that Assistant Secretary for Health, Dr. Rachel Levine, is our Brandt Lecturer this year. Dr. Edward Brandt Jr. served as Assistant Secretary for Health in the 1980s when AIDS was first sweeping the nation. Like Dr. Brandt, Dr. Levine is leading the nation's public health response at a time when a novel virus not only threatens public health, but also makes it clear to us why we must overcome prejudice and advance health equity. Before we have the great pleasure of hearing from Dr. Levine, I'm pleased to introduce Gary Raskob, who is Dean of the Hudson College of Public Health at the University of Oklahoma Health Sciences Center. Dean Raskob was a longtime colleague of Dr. Brandt, for whom this lecture series is named, and has been a great friend and colleague of our school, and in fact, of all of those involved in public health across the country. Gary, take it.
Great. Thank you, Lynn. Thank you so much for the warm welcome and kind introduction. And it's wonderful again to be back with colleagues and you and Susan and all the colleagues at the Milken School and also the Jacobs Institute for this this lecture. I'll say a few words about Ed, and then I'll really just give three quotes that I think that we had during his retirement party that I think are still very appropriate to the situation today and resonate, I think, with many of us about what an incredible leader Dr. Brandt is. I want to also thank and welcome all of Ed's family who are joining us here today and look forward to visiting with you again soon in Oklahoma. Ed Brandt was born in Oklahoma City on July 3rd, 1933. He married Patricia Lawson and they had three sons, Patrick, Edward Brandt III, and Rex. Dr. Brandt initially studied journalism at the University of Oklahoma before switching to mathematics. After earning a bachelor's degree, he earned a master's degree in mathematics at Oklahoma State University. But then he came back to the University of Oklahoma to earn his medical degree and his doctoral degree in biostatistics and epidemiology from our College of Public Health. Dr. Brandt had a long distinguished career in both academic medicine and public health, serving in numerous key administrative roles at the Graduate College, ultimately then becoming Dean of the University of Texas Medical School, and ultimately the Vice Chancellor for Health Affairs for the entire University of Texas system. Many of people on the call today will know that we completed a momentous football game last Saturday, and Dr. Brandt, despite living in the heart of Texas, always had his OU colors prominently displayed and wearing them. But it was really in 1981 that President Reagan tapped Dr. Brandt to serve as Assistant Secretary of Health in the US Department of Health and Human Services. Dr. Brandt really is known for two major signature achievements during his few years of leadership there. One was his stewardship and guidance during the beginning of the AIDS epidemic, as Dean Goldman mentioned. And that was really critical. And the other is what we're really honoring today, and was really striking when we think back about, you know, where we are, the discussions about women's health and his vision. But he was given the title as the godfather of women's health, and he initiated the Women's Health Initiative at the National Institute of Health and was a strong supporter throughout his career for advancing women's health very significantly, including at the international level. So in closing, I just want to read you a couple of quotations that were given to us on the occasion of Ed's retirement before his passing. First, Dean James Curran from the Rollins School of Public Health at Emory University and former head of HIV services, who worked so closely with Ed during his career. Dr. Ed Brandt provided tremendous leadership for the US Public Health Service during the early 1980s. Thanks to Ed Brandt, the US Public Health Service agencies were able to focus on the emerging epidemic and work closely to define the scope of problem, garner public support, identify modes of transmission, develop prevention recommendations, and identify HIV as the cause of AIDS. His science-based leadership and calm judgment were crucial during those tense times. And then I'm going to just quote two politicians on the opposite sides of the aisle. And when we think of today's environment and partisan environment, we also can see when you hear these quotes, what an incredible individual Ed was in navigating and trying to bring people together for the good of public health. Ed Brandt served as the Assistant Secretary of Health at a time when the AIDS problem was just coming into focus. He played a critical role in helping members of Congress, as well as people in the Reagan administration and the public at large, to understand and come to terms with this new and serious threat. His knowledge and low-key approach were perfectly suited to the task. He was at all times a gentleman, as well as a creative and public-spirited leader. His deep principle and unflagging ethics transcended politics. He retained his focus as a compassionate physician with deep concern for the health and well-being of the people of the nation. U.S. Representative Henry Waxman. And the last quote, I remember Dr. Brandt from his time as Assistant Secretary. His scholarly intellect and family doctor's bedside manner was a refreshing addition to Washington, D.C. His leadership, knowledge, and ability to work with colleagues across the political spectrum helped steer the nation through difficult times and into a new age of health policy, U.S. Senator Orrin Hatch. I think if any of us were to have those kind of laudatory quotes from two individuals on such opposite poles of the political spectrum, we would be very proud indeed. And I think Ed emulated all of the things that we see as good and decent about public health. I know Secretary Levine, he would be honored and delighted to know that you are speaking at this event today. And we thank you for doing that and for helping us to commemorate his legacy and his contributions to public health. Thank you, and I'll hand it back to you, Susan.
Thank you, Gary. You tell stories about Dr. Brandt, and I remember him well, not from his time as Assistant Secretary, but later on. And he was, throughout his life, such a champion and such a strong supporter that indeed he was the godfather women's health for many of us who've worked in women's health policy for quite a while. So it's lovely to hear those remarks. And it's really, as both of the deans have said, it's really appropriate that this Brandt lecture is now we're able to welcome the current Assistant Secretary for Health, Dr. Rachel Levine, as our speaker. She has taken on a role of and a responsibility within the Department of Health and Human Services and in our nation at such a critical time in our history and our critical time in our public health history. And I think she's going to be, I'm really looking forward to this. But let me introduce you properly, Dr. Levine. Dr. Levine is the 17th Assistant Secretary for Health in the Department of Health and Human Services. But she comes to us from Pennsylvania, where most recently she was the Secretary of Health there, and prior to that, the Physician General. But her background is as a pediatrician and specialist in adolescent medicine, very relevant to women's health in her work across her career. And she has done so much already in addressing the health of us all, and with a particular interest and focus in areas related to women's health at each point of her career. So I'm really looking forward to hearing what the priorities and interests and thoughts about where we're moving forward in women's health, from these COVID times and moving forward into the future. Because Dr. Levine is clearly a public health leader who has really committed to, again, the health of us all. And I welcome you to this GW University of Oklahoma Brandt lecture and look forward to your remarks. Thank you, Dr. Levine.
Well, good afternoon, and thank you so much for that kind introduction. And thank you for inviting me to give the Edward N. Brandt Jr. Memorial Lecture in Women's Health. It is just so meaningful to me to be able to give this lecture in honor of one of the 16 Assistant Secretaries for Health who served before me. And as we were talking right beforehand, his picture is right outside my door. Dr. Brandt was a visionary in his time. He studied and taught about the health issues of his day, but he truly took the time to study the seismic changes taking place in the late 20th century. And nowhere was this more evident than in his understanding of the changing health needs of women. In 1985, he wrote, quote, "Women in America are involved in a spectrum of activities today that were barely on yesterday's horizon. They are making significant contributions to America and are looking forward to the future. But with this panoply of opportunity has come the need for all of us to assess how the health risks for women are also changing in response to this new set of demands," unquote. He went on to insist that the focus should not only be on reproductive health, but rather devoted to assessing the problems of women's health in the context of the lives of women in America today. So we at the Department of Health and Human Services and myself at the Office of the Assistant Secretary for Health still share Dr. Brandt's deep commitment and understanding of the changing health demands and challenges that women face. In fact, women's health and health equity in general are one of my priorities as the Assistant Secretary for Health at HHS. And I am truly heartened by the progress made for the inclusion of women and minorities in research and the commitment in moving the bar forward for women's health and minority health. But we still have, even in 2021, a long way to go. Clearly, we are challenged by, as you mentioned, COVID-19 and the greatest pandemic that the nation and the world has seen in over 100 years. But COVID-19 has not affected all of us the same. COVID-19 has disproportionately impacted women, from developing really a completely new work-life balance to making tough financial decisions, and women often serving as the caregiver in the family. 2 out of every 3 caregivers in the United States are women. And women who are caregivers have a greater risk for poor physical and mental health, including depression and anxiety. Now, we are seeing an increase in mental health issues during COVID-19, which includes depression, anxiety, it includes overdose deaths, what I'll talk about in a minute, but also includes eating disorders. So as you mentioned, pediatrics and adolescent medicine was one of my significant fields of my academic career at Penn State. And I was able to start and run the eating disorder program there for children and adolescents and adults. And although we do see males with eating disorders, we see far more females with eating disorders, and that includes, teenagers with eating disorders and young adult and adult women with eating disorders as well. And so addressing all of these mental health issues is absolutely critical as we develop resilience and recovery as we move forward as a country through and from COVID-19. And so as your Assistant Secretary for Health, I am committed to using every tool at my disposal, building off methods that I found that worked at the state level, but also critically building partnerships across the Department of Health and Human Services and either other agencies as we address all of these issues. The United States is facing an overdose epidemic that has prematurely ended too many American lives and has actually worsened during the COVID-19 pandemic. In Pennsylvania, we were so hopeful in 2018 as we had made progress of the overdose epidemic, which affects women almost as much as it affects men. But things have worsened so significantly in 2020. More than 95,000 drug overdose deaths are predicted to have occurred in the United States in the 12 months ending in September 2021, the highest number of overdose deaths ever recorded in a 12-month period, according to provisional data from the CDC. And this is unfortunately continuing to accelerate through COVID-19. The alarming increase in overdose deaths really underlines the need for more accessible treatment services. And so we are focusing on prevention services. We are focusing on harm reduction services, including the distribution of the life-saving medicine naloxone. But we have to focus on treatment, and studies have clearly shown that medication-based treatment supports long-term recovery from opioid use disorder. And we have to get past the stigma associated with the disease of addiction. And we have to get past the stigma that somehow maybe a treatment and a recovery supported by medication is somehow not the same. A recovery supported by medication for opioid use disorder is exactly that. It is a recovery with medication for opioid use disorder. And that is why at HHS, we issued new practice guidelines for the administration of buprenorphine for treatment of opioid use disorder, which exempts eligible practitioners from many of the federal certification requirements for their X waiver, including those for training, counseling, and other ancillary services. So we can't do away with the X waiver completely. That would take an act of Congress, but we have made it much more easy for patients, for physicians and other medical providers to get their X waiver from the DEA so they can prescribe buprenorphine medications. And we want to expand access to treatment and reduce stigma and integrate medication with opioid use disorder care. We want to integrate that not only in terms of addiction medicine specialists, but to integrate it into primary care services so that people get the help they need. With the nation's mental and substance use disorder needs squarely in focus, Secretary Becerra has also established a new Behavioral Health Coordinating Council, the BHCC. And I am so proud to co-chair the BHCC with Dr. Miriam Delphin-Rittman, the Assistant Secretary for Mental Health and Substance Use. And this is comprised of senior leadership and principals from across the department. And we want to facilitate collaborative, innovative, transparent, equitable, and action-oriented approaches to addressing the Secretary's behavioral health agenda. And we will be working to do that, addressing issues of the disease of addiction and overdoses, as we've been discussing, addressing the pediatric behavioral health needs, which are in really a crisis that we are seeing across the nation, working to integrate behavioral health and physical health. That has really been one of the hallmarks of my career, being able to work to integrate behavioral health and physical health, mental health and traditional medical issues. And then also working on all the data that is necessary and working on specific action-oriented outcomes. So we'll be working on that. The work has started, and we're continuing to work on that every day. Now, amid the COVID-19 pandemic, our continued action to ensure the mental and physical well-being of women has never been more important. And so I want to highlight our Office of Women's Health within the Office of the Assistant Secretary for Health. So we have an outstanding Office of Women's Health with great leadership that works to provide critical national leadership and coordination across health and human services, across other agencies in the administration, through policy, education, and innovative programs aimed at improving the overall health of women and girls throughout the life course. This actually marks the 30th anniversary of the Health and Human Services Office of Women's Health, or OWH, which was created by Congress in 1991 as a federal office dedicated to improving the health of American women by leading a comprehensive women's health agenda. And the creation of the Office of Women's Health was really made possible by the groundwork done by Dr. Brandt, who also led to Dr. Vivian Pinn, dubbing him, as it was mentioned previously, quote unquote, the godfather of women's health. I didn't know that before I was invited to give this lecture. And I mean, what could be a more fitting tribute to his life and career? So today we empower women to protect their health in many different ways, but I'll give you some examples. Much needed and actionable health information on topics such as vaccinations. And we were just talking a little before about public health in this era and the critical importance of vaccinations, which are really one of the public health victories of the 20th and the 21st century. And so many vaccinations that help children and teens and adults, that help women, and now are absolutely critical to our success in overcoming COVID-19 and our safe and effective vaccinations. Nutrition. Now, you just saw evidence today of the FDA putting out guidance about salt intake. And so our Office of Women's Health, working with our Office of Disease Prevention and Health Promotion, working with the FDA, working with the NIH, working with the CDC on nutritional guidelines for women. Heart health, mental health, as I've been just discussing, HIV/AIDS, breast cancer, and maternal health. And that is just a few of the different issues that our Office of Women's Health is working on. We also collaborate with the Office of Women's Health, collaborates with our Office of Population Affairs on issues of reproductive health for women, including our teenage pregnancy prevention program and our Title X reproductive health program. So, the times keep changing. There was a song about that. I'm old enough to know a song about that by Bob Dylan. And so too have platforms we use to promote health and well-being. So, when the Office of Women's Health was created in 1991, social media was, putting flyers up on a bulletin board. I still, of course, remember that. Facebook was nothing like it is now, and tweets were sounds that came from birds. But now we have websites such as womenshealth.gov and girlshealth.gov, in addition to a virtual health information gateway, which serves as a vital clearinghouse for health research and accurate data on really almost any health topic affecting women. And we share the latest news in women's health via the internet and on social media. And our most concentrated communications efforts center on leading national campaigns and observances to help women and girls achieve positive health outcomes. Now, I had mentioned the collaboration with our Office of Women's Health with the Office of Population Affairs. And that includes our Teenage Pregnancy Prevention Program, as I mentioned, and also our Title X program. Family planning and the decrease in the unintended pregnancy rate and the teenage pregnancy rate are widely considered one of the most important public health achievements of the 20th century. And in my field of adolescent medicine, I have been right there in terms of Title X and in terms of family planning for teenage girls and for adult women. I had the opportunity to work in a Title X program in my adolescent medicine fellowship at Mount Sinai Hospital in 1987 to 1988. I'm certainly dating myself, as well as actually running a Title X program in Hershey, Pennsylvania, when I joined the faculty there and the staff at the Penn State Hershey Medical Center in 1996. Title X is the only federal program exclusively dedicated to providing contraceptive and other family planning services, and has been an absolute critical element in the success that we have had in decreasing the unintended pregnancy rate and the teenage pregnancy rate over the last 30 or more years. On January 28, 2021, President Biden issued a memorandum on protecting women's health at home and abroad, directing HHS to review changes that were made in the 2019 Title X final rule and consider as soon as practical whether to suspend, revise, rescind, or publish for notice and comment proposed rules revising and rescinding those regulations. We did conduct that extensive review, and just 9 days ago, on October 4th, 2021, HHS amended the Title X family planning regulations to restore access to equitable, affordable, client-centered quality family planning services for more Americans. This access is critically important for all clients for Title X programs, especially for low-income clients in the Title X program, which creates opportunities for realigning the nation's family planning program with nationally recognized standards of care and improving the health of communities that have been historically underserved. Our new 2021 regulations also reinforce the program's central tenets of quality, equity, and dignity for all individuals who seek Title X services, and modernizes the more than 50-year-old program to reflect our current healthcare system. So we're very, as you might know, changing rules and regulations in the federal government can be challenging and time-consuming. I don't want to disillusion anybody, but I'm sure Dr. Brandt would have known this. There's a certain bureaucracy associated with the federal government. And we were able to do this in the first 10 months of the Biden-Harris administration and to release that rule on October 4th, which was a major achievement. And I'd like to thank all of our staff and all of the staff involved throughout HHS working to make that achievable and possible. Another focus, and you can understand this in my field of pediatrics, is maternal child health. A healthy future begins with excellent maternal health and child health, and a healthy future begins with a healthy childhood and better care for our moms. It is a tragedy that the United States has the highest maternal mortality among high-income countries. And we must do better, and we will do better. This is an absolute priority across HHS, across the administration. And the Office of Women's Health, and in my office of the Assistant Secretary for Health, has released an action plan to improve maternal health in America. The action plan outlines a holistic approach to care that proactively identifies risk factors for poor maternal health outcomes and engages a comprehensive set of resources, including clinical, behavioral, and social support to help mothers and their babies attain optimal pregnancy, birth, and post-delivery outcomes. And this is work that's being done across HHS. The CDC has been very involved with these maternal health programs. I know this from my work now, but also my work in Pennsylvania, where with legislation from the Pennsylvania legislature, we were able to establish a statewide maternal death program review committee, a maternal death review committee, and to be able to be looking at the principal causes and the patterns for maternal deaths in Pennsylvania across the state, collaborating with the Philadelphia maternal death committee that has been established for a number of years now. And this was done with help from the CDC. Our efforts at OASH to improve maternal and infant health includes its only natural breastfeeding campaign that encourages breastfeeding initiation and continuation, particularly among African American women. Again, health equity cross-cuts everything that we're doing across HHS. And I know that from the importance of breastfeeding from my work as a pediatrician for almost 40 years now, in terms of working with women in terms of breastfeeding. It's a critically important, strongly supported by the American Academy of Pediatrics, of which I've been a proud fellow for, again, almost 35 years now. And through, of course, the American College of OBGYN. These serve as a launch pad for OWH initiatives designed to address significant disparities in maternal health that contribute to poor outcomes. I also want to talk about a new office that we have that impacts women and really impacts all of us. And that is our new Office of Climate Change and Health Equity, affectionately called OCHE, the Office of Climate Change and Health Equity. Because we know that climate change also negatively impacts maternal health outcomes, increases the risk of preterm birth, pregnancy-related complications, and maternal mental health. So we have launched this Office of Climate Change and Health Equity to address this and other health impacts caused by climate change. We used to think of the impacts of climate change as being sort of an existential threat for the future that we'd worry about in 2050, but that is clearly not true from the headlines that we see today. The impacts of climate change are happening right now. You can see this from severe heat-related negative health outcomes in the Southwest and heat-related negative health outcomes in the Northwest, with 100+ degree temperatures in Portland that we saw this summer and in Seattle. We can see this from wildfires throughout the West and throughout the world that impact health. We can see this from hurricanes and flooding that have gone from Louisiana and Mississippi to Tennessee to New Jersey and to New York. So we are seeing the impacts of climate change now. So we are certainly committed to this new office's mission to protect the health of those most burdened by the health impacts of climate change, knowing that many of those people are also the same people burdened by health disparities in general and by the health disparities associated with COVID-19. So in terms of maternal mortality, going back to that, while the United States has one of the most technologically advanced healthcare systems, the US maternal mortality rate remains exceptionally high, higher than really almost all other developed countries. As many as 2/3 of pregnancy-related deaths are preventable. And for every maternal death, many more women are experiencing serious complications throughout the time of delivery and morbidity. Of particular concern, our pregnancy-related mortality is 2 to 3 times higher. It is 2 to 3 times higher in non-Hispanic Black, as well as American Indian and Alaska Native women, compared to white, Hispanic, and Asian Pacific Islander women. So, I mean, we saw this in Pennsylvania as well. To be honest with you, the maternal mortality rates among Caucasian women was pretty flat, but the maternal mortality in Pennsylvania was sky high for non-Hispanic Black women. And as we look in Indian country, among American Indian, as well as in Alaska Native women, compared to others, significant higher rates of maternal morbidity and mortality. So now is the time to address these disparities. And like Dr. Brandt, we are grounded in the present, but also looking to the future. And so reducing health disparities and achieving health and gender equity is that future. Health and gender equity are essential to improving health outcomes. That recognizes today that most women and girls might have equal access to some care and treatment, but at-risk and underserved populations, like I've been describing, have a different starting point and different access to those care and treatments that accounts for those increased adverse health outcomes. And so we need to achieve health equity and health outcomes for every girl and every woman in the United States. I know all of you know this, but I'm going to say it anyway. I'm going to talk about vaccines again for a moment. That I really want to encourage everyone to get your COVID-19 vaccine. But not only that, not only to make sure that you get your own vaccine, but to help others in your family, in your community get vaccinated as well. The more people that are vaccinated, the quicker we can move through and then past the COVID-19 pandemic. But also, as we are focused on COVID-19 vaccines, it's critically important that we focus on routine vaccines for all ages. And to that end, the Office of Women's Health, working with our Office of Infectious Disease and HIV/AIDS policy, has launched an HPV Vax Now campaign, Human Papillomavirus Vax Now campaign, with the long-term goal of increasing HPV, human papillomavirus vaccination rates in young adults. I'm sure you know, but HPV, I remember this was a board question in adolescent medicine. HPV is the most common sexually transmitted infection in the United States. HPV is the most common sexually transmitted infection in the United States, causing nearly 36,000 cases of cancer in women and men, which are most of which preventable cases of cancer with the HPV vaccine. And so we know that women in the United States make approximately 80% of the healthcare decisions for their families. And we need to address vaccine hesitancy among women. We need to listen to their concerns, encourage an open dialogue so they feel informed and confident so they can get vaccinated. Then they can encourage their children to get vaccinated with the HPV vaccine and their family members vaccinated with really all of the large number of vaccines we have available for children, for adolescents, and for adults. In terms of chronic disease prevention across HHS, we are striving to support chronic disease prevention and better access to healthcare for women. For example, the transmission of HIV/AIDS from mother to child has been significantly reduced through routine screening, routine screening and the use of antiretroviral drugs approved by the FDA. That's what I saw when I was a pediatric resident in 1983 at Mount Sinai Hospital in New York City, was this vertically transmitted HIV that has been significantly reduced through routine screening and the use of treatment. Policies such as the Part D of the Ryan White HIV/AIDS program and supportive HIV testing and linkage to care in Title X family planning centers through the Secretary's Minority AIDS Initiative Fund have helped create just a much better system for HIV/AIDS disease management. Similarly, the National Action Plan on Breast Cancer and the National Breast Cancer and Cervical Cancer Early Detection Programs have provided comprehensive strategies to address breast cancer in the United States. For HHS, this means building on the Affordable Care Act to ensure that more people have access to healthcare. So we identify cancers earlier and lift this unequal health burden, driving higher rates of advanced cancers among vulnerable groups. We are meeting the needs of today, working to identify the needs of tomorrow. So we are launching programs and partnerships designed to screen for postpartum depression and surveillance and best practices for opioid addiction and pregnancy, assess low-income, uninsured, and underinsured women for cardiovascular disease risk factors, fund perinatal quality collaboratives, state and multi-state networks of teams working to improve the quality of care for mothers and infants. We had that in Pennsylvania, gathered through work with the CDC, gather data and information through the National Survey of Family Growth to inform future programming and funding, and improve the health and safety outcome for survivors of intimate partner violence and health human trafficking. So I'm going to finish up. We've accomplished so much, but we have more work to do. And improving women's health outcomes and achieving health equity can't be accomplished by government alone. So we need public-private partnerships. We need public partnerships with academic medicine. I too have come from academic medicine and academic public health. We need each and every one of you to work with us. In the current climate of COVID-19, when anxiety and uncertainty is high, our determination remains even greater. It is so reassuring to see the tireless individuals who are working in partnership with the federal government and the private sector to advance the health and well-being of women and girls throughout the nation, people like you. So with help of the institution, like the Jacobs Institute, committed leaders and thinkers just like you, committed public health schools at GW and at University of Oklahoma, 30 years from now, we can look back at this moment as the beginning of a renewed commitment to improving the physical and mental health and well-being for all women and all girls. And I'm getting a little bit hoarse. Thank you so much for your attention. I'm pleased to answer your questions.
I'm going to applaud for the entire audience because we can't hear them on a webinar, but I know they're out there applauding your remarks, and thank you so very much. Before we move on to the next stage, I want to remind two things, is that if folks could put any questions that you have into the Q&A, we'll moderate those questions and ask Dr. Levine for her thoughts in response to your questions. So go ahead and pop them into the Q&A box. The next thing I want to do, and it's a bit awkward us being on a webinar and on video, but if we were in person, I would present you with a plaque to honor you and recognize your being our Brandt Lecturer in Women's Health in 2021. And lo and behold, there it is.
And here it is. It's absolutely wonderful. I will treasure it. It's going to go right up in our office, and I will absolutely treasure this. It's been a tremendous experience working with you all, and I truly appreciate the opportunity, and it's just so special since it is the Edward N. Brandt Memorial Lecture.
It is. I think something that Dean Raskoff mentioned was how the approach that Ed took was always very science-based, and goodness knows with the restoration of HHS as a science-based led agency is wonderful, and so you play that very significant role as well. So thank you for that. Let me check on questions. And like I said, I'll encourage people to set questions. I had take the moderator's prerogative, and you had so many things. First of all, I wanted to thank you about Title X on behalf of everyone in the country who values access to high quality, evidence-based family planning services. It's really wonderful to have the Title X program restored again to one that is actually serving people. But the question I had is not related to that, and it goes back to one of your first comments and something I know you care a lot about, which is the opioid epidemic. You mentioned the loosening of the restrictions around buprenorphine or other medical assisted treatment options. We'd done some work a few years back, and I'm sure the situation is even worse, around pregnancy and opioid use, and how actually getting medication assisted treatment was difficult, if not impossible. And even when gotten, in the fact they would often get penalized for exposing a fetus to methadone or other treatments, and though in fact that is what is medically advised and indicated. So I just wonder if any of the programs that you are working on are going to be able to support more the issues around pregnant women and opioid use and treatment.
So thank you very much. It's a critically important point. So, obviously, pregnant women are at significant risk if they have the disease of addiction to opioids and opioid use disorder, and it puts their fetuses at risk. A significantly increased rate of premature births and low birth weight births, as well as fetal loss. And so the standard of care, as you mentioned, for women who are have the disease of addiction to opioids is to offer, in addition to counseling and therapy, medication for opioid use disorder. The standard of care has previously been methadone, and that has been used very successfully, but there's more and more evidence about using buprenorphine. And it is buprenorphine. It's not the combined product with Suboxone, with naloxone. It is buprenorphine medications. Really, we are working with SAMHSA and through our BHCC to increase the ability for OBGYNs to be able to have their X waiver, to be able to prescribe buprenorphine medications, because it has a much better outcome in terms of decreasing maternal and fetal morbidity and mortality. I'll give a shout out to actually McGee Women's Hospital and the University of Pittsburgh Medical Center, which has a fantastic program that we knew of when I was in Pennsylvania to take care of pregnant women with buprenorphine medications, to link them to care, and then after delivery to make sure that they are linked to care. Because after delivery, if a woman goes back to using these drugs of abuse, then that puts her and her baby and her family at significant risk, especially in the light of the fentanyl-related compounds that we're seeing, which are so serious. So I would highlight that program and the collaboration with OBGYNs, with addictions medicine specialists to help those women.
Thank you very much for that. I have some other questions coming in the pack here now. So one question comes in about, are there existing HHS interventions or strategies to address the vaccine hesitancy in women? Is there anything specific that you're trying to develop to get at women as often the medical decision makers in the family?
So we have specific materials for women through the CDC that we want people to access on the internet, but also we want physicians and other medical providers to be able to offer their patients in terms of recommending the COVID-19 vaccines. And so, we want to work at all levels. But what we're finding is that people aren't always, because of the politicalization that we have seen of the COVID-19 pandemic, people aren't always listening to public health authorities, whether at the federal, state, or local levels. And so we really need trusted community members to talk to their communities about our safe and effective and critically important vaccines. And so that includes public health, that includes the medical community, that includes others in the business community and others in the faith community. And so we actually have what we call our COVID-19 Community Core. You can sign up and be officially part of the core, or just talk about it in your communities, the importance of these vaccines. We also have to work past the misinformation that we are seeing on social media and other media platforms, and then circulates throughout communities in the United States. And our Surgeon General, Vice Admiral Murthy, is working on specifically materials to try to combat that misinformation that unfortunately is contributing to vaccine hesitancy.
Thank you. Really important work. I have another question here from Audrey Shepard, who is one of the former directors of the FDA Office of Women's Health. And she's asking about what HHS is, and perhaps with the administration, is doing to ensure that contraception is covered 100% under the Affordable Care as a preventive service. And she notes that under the previous administration, that these rights were eroded with lots of, obviously under changes in the regulations as well. Are you going to be addressing that?
Yes, we will. So, under Secretary Becerra's leadership, we are just so collaborative at HHS. So, with our Office of Population Affairs and Women's Health at OASH, we are working with FDA, but we also have to work with other colleagues. We have to work with CDC. We have to work with CMS. in terms of Medicare, Medicaid, and reimbursements, as well as HRSA, to make sure that evidence-based contraception, FDA-approved contraception, is available and affordable for everybody. So we will absolutely be doing that. It is critically important. We have evidence that we have lost, thousands and thousands of title care participating agencies across the United States. And we have lost, hundreds of thousands of patients from the Title X program, maybe almost a million or more patients. And so we're going to work to, as the president says, build back better. And we're going to get those patients back in the Title X program and make sure that they have the reproductive health services that they need and deserve.
And that actually sort of leads on to another question that was asked as well about how long it's going to take to sort of restore the Title X network after it was sort of, because of the grants being changed in the past and a lot dropped out.
Right.
Do you have an idea of how much time it will take to get it?
Well, that's why it was so critical to get the new rule out, because this is now the rule. I mean, we put out the rule for comment in the spring and then had hundreds of thousands of comments that we had to answer, and then worked to have the rule out come out, so that as Title X puts out its new grants, its new proposal for grants over the next month, this is the rule that applies. And so as the new grants are awarded in the spring of 2022, it'll be with this new rule. And so we expect that we're going to work very rapidly to build back better by the spring. We'll see how long it takes to completely build it back, but we are hopeful for a very promising spring for Title X.
Wonderful. Thank you. We have another question here from Tristan Taramino, and the question is about appreciating that your comment to mental health as integral to overall health. In my state, the majority of therapists don't take insurance, making them inaccessible. Those who do are overwhelmed, and the demand simply can't be met. And this is, I think, particularly true, and I'll tailor this towards women who are, many whom during the lost their jobs, are at home taking care of the children who no longer have access to schooling, are being disproportionately affected in those ways, and obviously having profound impacts on their mental health and increased depression and so forth, anxiety. And so the question is about what can your office do to increase access to affordable mental health services?
So this is a critical thing that we're working on. So as I mentioned, we have the Behavioral Health Coordinating Council, of which I'm co-chair with Dr. Miriam Delphin-Rittman, the Assistant Secretary for SAMHSA. And so we have specific groups working with all of the what I call optives and staff divs, all of the operating divisions and staff divisions at HHS, looking at these issues to improve access to care. So we have everyone at the table. We have our office and SAMHSA at the table, of course, but we have CDC and NIH. We have HRSA. We have ARC. We have CMS at the table. Name a optive and staff division at HHS, and it's at the table, because we need to do this now. The mental health, it's really a crisis, and I'm including substance use disorders as part of that. It is a crisis that we're seeing across the country. And so we need to work to integrate mental health into physical health services. We need to have mental health professionals in our HRSA community health centers. We need to have more and more mental health professionals in pediatricians' offices, in OBGYN offices, in other family medicine offices throughout the country. We need to integrate not only therapy, but also access through psychiatry as well. We need more programs like Project ECHO, which is a great program where specialists can work with primary care providers throughout a region or throughout a country. Project ECHO was designed in New Mexico and is a fantastic hub and spoke model program for education about many topics, but including mental health and substance use topics. We need to use more and more telehealth to be able to expand access to mental health. I mean, one of the positive outcomes of the COVID-19 pandemic is the expansion of telehealth services throughout the United States. We are working to continue that so that it doesn't end as we work through the pandemic. And that includes telemental health. But there is a health equity component to that, because if you do not have programs like this, like Zoom, or if you do not have computers or access to, to fancy iPhones, then you can't access telehealth services. And so you really need to have a strong health equity component, broadband equity component to that. So we're going to be working on all of those things. That work has started now, involving other secretaries' leadership, the entire agency.
That's really good. I think we have time for one more question, and that was, you haven't really spoken about, there's also the Gender Council that's being set up at the White House. Can you talk about your role and HHS's role in that, and what you see that doing?
So I'm very pleased to have a seat on the Gender Policy Council for HHS. And I staff are working closely with the Gender Policy Council. They're working on finishing up a lot of their recommendations. Don't know exactly when they're going to release them, but that has been a whole of government approach, which is really the hallmark of the Biden-Harris administration, looking at gender equity. And of course, we have been promoting the issues in terms of health. But for me, you have to understand, with the social determinants of health, really, health is in all policies. So if you're talking about educational opportunity for girls and women, that's a health issue for me. If you're talking about transportation, that's a health issue. If you're looking at housing and HUD, that's a health issue. If you're looking at economic opportunity for women and a living wage, that's actually a health issue. So health to me is in all policies, but the Gender Policy Council is really such an innovative and progressive approach to looking at this, and I'm just so proud to be sitting on it.
Do you see it being able to, like, for HHS to be able to work with, for example, the education department in doing actual projects? That's
exactly right. And it's important to note that has a national perspective, but also has an international perspective, working with the State Department and other agencies as well. So the Gender Policy Council has a global perspective in terms of women's issues.
Great. Well, I think we've been delighted that you've been willing to spend this hour with us, and I'm sure there are, hopefully, I think what a lot of people on this webinar would love to work with you, would love to work with the Office on Women's Health, would love to work with the different agencies to advance women's health in a lot of different ways. And so we look forward to being able to do that in the future. Thank you.
Thank you so much for the opportunity. It's so meaningful to be able to give the Edward and Brandt Memorial Lecture in women's health, to one of my predecessors. I mean, it's an honor. And it's an honor, especially as you mentioned that his family is here. So thank you for the opportunity. Appreciate it.
And I'd like to thank Dean Goldman and Dean Raskob and the support of the universities for this over the years to be able to continue the Brandt Lecture the way it has been. Lynn or Gary, do you want to final words? Or
thank you. Terrific. We look forward to continuing the great cooperative effort.
And our thanks as well, and especially to you, Dr. Levine, for finding the time today during this time when there's so many pressing things going on. We just can't be more grateful to you for sharing all of that with us today. Thank you.
Thank you.
Thank you, and thanks to everyone for coming. And with that, we will wrap up our 13th annual Brandt Lecture on time today. Thank you very much. Thanks for coming.